Hi, my name is Dana Leefers, and I'm currently a PGY2 ambulatory care pharmacy resident. And today I'm going to be talking to you about treatment strategies for diabetes, part 2, with an emphasis on insulin therapy. The different insulin formulations are categorized into short-acting, rapid-acting, intermediate-acting, long-acting, and premixed, and this is based on the pharmacokinetics. Insulin activates your insulin receptors and works similarly to the endogenous insulin that you produce. It does cause weight gain, and the hypoglycemia risk is very high with insulin use. The A1C efficacy is theoretically unlimited. And note that the administration of insulin is going to vary depending on the product. Some formulations will be in pen form and some will come in vials. Insulin was first isolated in 1921, and under normal physiological circumstances, insulin is synthesized in the pancreatic beta cells and stored in the vesicles of the Golgi apparatus in relatively high quantity. In the vesicles of the beta cell, insulin is stored as hexamers, which form as a result of the high local insulin concentration in the presence of zinc. When released into the circulation, these insulin hexamers dissociate to form dimers and monomers, and because of the dilution effect and zinc diffusing away. Insulin molecules in solution exist in dynamic equilibrium as monomers, dimers, and double dimers or tetramers, triple dimers, hexamers, and high-order aggregates. The rapid-acting insulin products, including insulin Lispro or Humalog and insulin Aspart or Novolog, were reconstructed to weaken the propensity for insulin to self-associate through charge repulsion sites. The way that this was done is insulin Lispro, the proline at the position B28, was moved to B29, and the lysine at position B29 was moved to B28. The advantage of this analog is its very low propensity, in contrast to human insulin, to self-associate in anti-parallel fashion and form dimers. Insulin Aspart or Novolog is actually made by Baker's yeast and is created by the substitution of the B28 proline with a negatively charged aspartic acid. This modification reduces the normal monomer-to-monomer interaction, thereby inhibiting self-aggregation. Insulin glulysine, or Apidra, was formulated by substituting a glycine for asparagine at B3 and glutamic acid for lysine at B29. Its absorption, action, and immunologic characteristics are similar to those of the other rapid-acting insulins in that the modifications weaken that propensity for the insulin to self-associate or aggregate. Because of these modifications, the rapid-acting insulins have a very fast onset of action, typically 5 to 15 minutes, with a peak of 1 to 2 hours, a duration of 4 to 6 hours. These products should be given within 5 to 10 minutes before a meal due to the rapid-acting pharmacokinetics. Short-acting insulin, or regular insulin, includes Humulin R and Novolin R. In high concentrations in the vial, this regular insulin molecule that looks the same as our insulin that humans physiologically produce, the regular insulin molecules self-aggregate in an anti-parallel fashion to form dimers that stabilize around zinc ions to create insulin hexamers. The hexameric nature of regular insulin causes a delayed onset that prolongs the time to peak action. After subcutaneous injection, the insulin hexamers are too large and bulky to be transported across the vascular endothelium into the bloodstream. As the insulin depot is diluted by interstitial fluid and the concentration begins to fall, the hexamers break down into dimers and finally monomers. This results in 3 rates of absorption of the injected insulin, with the final monomeric phase having the fastest uptake out of the injection site. The clinical consequence is that when regular insulin is administered at mealtime, the blood glucose rises faster than the insulin, with resultant early postprandial hyperglycemia and an increased risk of late postprandial hypoglycemia. Therefore, regular insulin should be injected 30 to 45 minutes before the meal to minimize the mismatching. The short-acting insulin products have an onset of 0.5 to 1 hours with a peak of 2 to 3 hours and a duration of 6 to 10 hours. Intermediate-acting insulin includes your NPH products, such as your Humulin and your Novolin. NPH insulin is an intermediate-acting insulin whose absorption and onset of action are delayed by combining appropriate amounts of insulin and protamine so that neither is present in an uncomplex form. After subcutaneous injection, proteolytic tissue enzymes degrade the protamine to permit the absorption of insulin. The dose regulates the action profile. Specifically, small doses have lower, earlier peaks and a short duration of action, with the converse true for large doses. The action of NPH is highly unpredictable and its variability of absorption is over 50%. Intermediate-acting pharmacokinetics include 2 to 4 hours onset, a peak of 4 to 10 hours, and a duration of 12 to 18 hours. Your long-acting insulin product includes insulin glargine, or Lantus. The attachment of two arginine molecules to the beta chain carboxyl terminal and a substitution of a glycine for asparagine at the A21 position created an analog that is soluble in acidic solution but participates in the more neutral body pH after subcutaneous injection. These modifications shift the isoelectric point, which is the pH at which the molecule carries no electrical charge, towards a more neutral pH. Individual insulin molecules slowly dissolve away from the crystalline depot and provide a low continuous level of circulating insulin. It has a slow onset of action, about 1 to 1.5 hours, and achieves a maximum effect after 4 to 6 hours. This maximum activity is maintained for 11 to 24 hours or longer. Insulin detamere or levemir is another long-acting insulin product. The terminal thiourine is dropped from the B30 position and mysteric acid, which is a C14 fatty acid chain, is attached to the terminal B29 lysine. This fatty acid side chain not only increases self-association into hexamers and dihexamers, but also allows reversible binding of insulin detamere to albumin present in all tissues in the circulation. These modifications prolong the availability of the injected analog by increasing both self-aggregation in subcutaneous tissue and reversible albumin binding. The duration of action of levemir is mediated by slow systemic absorption of insulin detamere molecules from the injection site due to the self-association of the drug molecules. In addition, the distribution of insulin detamere to peripheral target tissues is slow because of the binding to albumin.